Hi, I'm Monica Morrow. I'm the Chief of the Breast Surgery Service at Memorial Sloan Kettering Cancer Center. So when is axillary dissection necessary after a sentinel lymph node biopsy? And the answer to this question depends on how much tumor there is in the sentinel node and whether the operation on the breast is a lumpectomy or a mastectomy. So we'll start with lumpectomy. If you're having a lumpectomy and radiation, axillary dissection is only necessary when there's cancer in 3 or more sentinel nodes, or if there's large amounts of cancer in the lymph nodes, so they're stuck together, which is what we call matted nodes, and that's only discovered during surgery. For women with cancer in only 1 or 2 sentinel nodes, multiple different prospective randomized studies have shown us that the chance of surviving breast cancer is exactly the same, whether you have a sentinel node biopsy or whether you have a complete lymph node removal with an axillary dissection. Not only is the chance of survival the same, but the risk of cancer coming back in the armpit is the same and is only about 1% at 10 years. What is different, however, is that there are fewer side effects with sentinel node biopsy alone, especially lymphedema or arm swelling, which happens in fewer than 5% of women after sentinel node biopsy, and in about 20 to 25% of women who have an axillary dissection, and even more if they have an axillary dissection plus radiation to the area of the lymph nodes. So this has really been one of the greatest advances in breast surgery in recent years, is our ability to avoid axillary dissection in large numbers of women who are having lumpectomy. In our published experience, approximately 80% of them, 85%, don't need an axillary dissection because they have disease in 1 or 2 sentinel nodes. Now, that only applies to women who have no enlarged abnormal lymph nodes to feel on physical exam before surgery, because those are the women who were included in the clinical trials. Now, the setting is somewhat different in mastectomy because, first of all, the studies that established the safety of this approach included very few mastectomy patients, and radiation is not always routine after mastectomy. And one of the ways we decide upon the benefits of radiation is based on how many lymph nodes are involved with cancer. So traditionally, if there has been any cancer in the sentinel nodes in a mastectomy, complete axillary dissection was necessary. So not only is mastectomy a bigger operation in the breast, but it's a bigger operation on the lymph nodes if there are cancer cells there. In more recent years, because there's been a lot more use of radiation to the lymph node areas after mastectomy, if it's clear, based on the finding of cancer in 1 or 2 sentinel nodes during surgery, that radiation is going to be given, then axillary dissection can be avoided. But oftentimes, all the information to make that decision is not available during surgery. So how often that occurs will very much depend on local practices regarding the use of radiation after mastectomy. The one time where axillary dissection is not indicated, whether you're having a mastectomy or a lumpectomy, is in patients who have what are called micrometastases or isolated tumor cells, which are very, very small amounts of cancer in the lymph node. And studies have shown that those can be safely managed without complete lymph node removal. So the decision about when to do and when not to do an axillary dissection has become much more complicated than it was in the past. But the net effect is it allows many women to avoid having complete lymph node removal and its side effects.